So there's just a little bit of a postscript on the atrial junctional lecture, which I kind of like to do after we've done all the practice so it doesn't confuse things. And what I'm going to talk about is sinus tach versus SVT. So, just when you think you're done, what we've got is sinus tach versus, again, PSVT, our definition of SVT. Okay? So when sinus tach is fast enough, the P waves become buried in the T waves and you simply cannot see them. So this means this is indistinguishable from this rhythm that we've been calling SVT, okay? Now, just so we're on the same page, what we've done so far is we've said there are 4 rhythms that come under our umbrella term of SVT or PSVT. And what are they? Junctional tach, atrial tach, and AVRT. Yeah. So I think that was the correct mother. Okay. So the thing is, the dirty secret is that this could be sinus tach. And whereas the reason we can get away with this umbrella term of SVT, of AVNRT, AVRT, junctional tach, and atrial tach, is we treat them all the same. Okay, all of those rhythms will respond, for example, to cardioversion. Okay. Now, somebody remind us, if we think, let's say the rhythm actually is AVNRT, so the one with the re-entry circuit that is going round and round and round and round the AV node. Why does cardioversion work to convert that to a normal sinus rhythm? Because cardioversion is very effective with SVT. Yeah, Cody.
Because it breaks that round and round circuit.
And then what happens?
Normal sinus.
Yeah. So the whole idea of cardioversion, regardless of what rhythm your cardioversion, and we're talking about synchronized cardioversion, is you're stopping the heart just for a moment with the idea that we're going to shake up the conditions that allow whatever that tachydysrhythmia is to exist, and that gives the sinus rhythm a chance to come back. Now, let's suppose you accidentally, because that would be the only reason why you would do it, because I know you wouldn't do it stupidly, so it would have to be accidental. Suppose you mistakenly cardioverted sinus tach for whatever reason. What happens if you cardiovert sinus tach? What do you think happens? So first of all, I'll tell you, the first thing that happens is everything stops, because everything always stops when you cardiovert something.
Cardiovert's just shocking, right?
Yes.
Okay.
Yes. And so cardioversion is synchronized cardioversion. When I say cardioversion, I'm distinguishing it from defibrillation. So the difference is I'm using a little bit less joule energy, and I'm syncing it so you don't hit that vulnerable period, that relative refractory period in
And
the
that's
heart.
different than pacing. Pacing
Yes,
continuous
pacing
shocking,
is
right?
to speed up bradycardias, and it's much less energy. Okay, so you cardiovert somebody who is in sinus tach, and it stops everything, and then what do you think happens? What happens then?
Start again?
It just comes back again. Remember? So this SA node still comes back. Do you think it's still tachycardic? It's probably faster, right? So if you cardiovert SVT, it's very likely to bring back a sinus rhythm because it breaks the re-entry circuit. But if you cardiovert sinus tach, it's very likely to bring back a sinus rhythm, which is what you had to begin with, but you're still in sinus tach. So, and you've caused your patient a lot of, pain for no good reason. Okay, so this is a problem. Okay, this is really a problem. Meaning a problem for you. It's a clinical problem. Okay, it's not an ECG class problem, because I'm going to tell you how we're going to deal with it in ECG class, and that's easy. But it's a problem when you're on scene, and you see something that looks like SVT and you think, oh, what am I gonna do if it's sinus tach? Whereas cardioversion is one possible treatment for SVT, it is never appropriate for sinus tach. If your patient is in sinus tach, how do you treat him? What do you do? Treat the underlying cause. So for example, if you think that the patient is in sinus tach because they're dehydrated, what do you do? Yeah, you give them fluids. If it's because they're hypoxic, you give them oxygen. You know, it's a lot of things we can't do the actual treatment, but we can get them to the hospital. Okay, but cardioversion is never going to help sinus tach. Okay, so what do? You walk on scene and you've got a patient that is in SVT, and you think, oh, I think I'm going to shock them. Oh no, what am I going to do? What if it's sinus tach and not SVT? Okay, and this is a real life problem. This is not theoretical. Okay, so a couple of things that will help you. So first of all, the upper range of sinus tach is age-related, and I'm going to say approximate equation for it is 220 minus the patient's age. So what does that mean? That means if somebody is 40 years old, okay, then you take 220 minus 40 and you come up with 180. That's the approximate number, that's the highest rate of sinus tach that person can go into. It's about 180. Remember, it's not precise. But what that means, if you're looking at something you think is SVT and the patient is 40 years old and the rate is, let's say, 200, does that make it more likely to be SVT or sinus tach?
SVT.
SVT, because it would be very unlikely for the 40-year-old to get their rate of sinus tach up to 200. Okay, so this can help you, but note that this formula is more useful at ruling sinus tach out than ruling it in. So, for example, the rate here is 170. I counted it up for you, and it looks like SVT. No discernible P waves. It's rapid. But could it be sinus tach? Well, let's say that the patient is 20 years old. Could it be sinus tach? Okay, it could be, right? Because what's 220 minus the patient's age? 200. So 170 is within it. Does that mean it is sinus tach? No. Sadly, no. It just makes it possible. So if this was your patient, a 20-year-old patient whose ECG strip looked like this, and you use the equation, you go, oh, darn it, is it going to be SVT or is it sinus tach? Then what are you going to do? What are some things you can do at this point? Patient's sitting there, alert and oriented. That's a hint.
History.
Okay, so what might make it more likely, do you think, to be sinus tach?
Asking like what led up to it.
Okay.
Cause.
Okay. Yeah, so we know that's why those underlying causes of sinus tach are so useful, right? Is that while it's true that a 20-year-old could have a sinus tach that is this fast, it's unlikely unless there's some underlying cause. And that's your job, is to find out the underlying cause. So for example, you know, if they're a paramedics student and they've been up all night, you know, drinking energy drinks, and you see a row of empty cans, there's a reasonable chance that's sinus tach. At that point you think, well, I don't think I'm going to cardiovert this patient because this could be sinus tach. Okay. So always take the patient's history and circumstances into account. Remember those underlying causes for sinus tach. Okay, so I'm just going to tell you. So the rate here is 180. Okay. Your patient is a 4-year-old female with a fever of 103. Is this more likely to be SVT or sinus tach? Yes, this is almost certainly sinus tach. Okay. However, your patient is a 40-year-old male who reports feeling chest pain while watching TV. Is this more likely to be SVT or sinus tach? SVT. So you see how this works? You take the patient's age and the circumstance, put it together, and come up with your best guess about what it is. Okay, so here's kind of the bottom line. So very rapid sinus tach versus SVT. It can be really difficult to tease these two rhythms apart without the patient's story, right? Does that make sense to everybody? You need the patient to say, was it you that drank all that Red Bull, you know? So when we see a strip with no story, you open up Huff and you see SVT, okay? You're looking at a book or you're looking, you know, at a handout and you see SVT. There's a couple assumptions that we make. One is, unless you're told otherwise, anytime you see something like this, we always assume it's an adult at rest. That's just the rules of it, okay? Everybody here is an adult at rest. They're not 4-year-old, you know. So for that reason, when you're trying to identify an isolated strip that looks like SVT, in this class, with no patient story, I want you to call it SVT, okay? Because without a story, you can't do it, so we're just gonna go with SVT. You know, far more likely it is SVT than sinus tach. Does that make sense? So like I say, it's not a problem in this class, but I'm sort of building this case of something that you're gonna have to worry about next year. Okay? So, don't go anywhere, but it'll take me a couple minutes to switch lectures, and I'm going to go to the ventricular